And Traci's also known as the Wound Wizard, and she's the chief medical officer at the Wish Clinic in Denver. She earned her Doctor of Medicine from the University of Texas Medical School in San Antonio and completed her general surgery residency at the University of Colorado Ann Medical Center campus with an additional vascular research training at the University of Utah. In addition to her medical training, she holds an MBA in healthcare executive leadership from the University of Denver. She's very loyal to Denver, obviously. Dr. Kimball is a board-certified wound specialist physician with over 12 years of experience in wound care across a diverse healthcare setting environment. In 2023, she fulfilled her vision by operating the Wound Clinic, a holistic research center dedicated to the whole person and to restoration, plus very innovative wound management. She deploys a lot of novel, impactful therapies, and we're just so delighted to have her as the chair of our advisory. And Traci's been the chair of our advisory for quite a while, and she's really steered us in a great direction. So she's going to go through this new device and why, and sort of the rationale why we crafted it. We listened to the clinicians in the field, and I'm going to hand it over to Traci to explain the rest. Thank you, Traci.
Thank you, Dr. Lunke, for having me, and of course, Histologics for sponsoring this talk. And welcome, everybody. Hopefully, we can get through this. And it's very self-explanatory. The product itself really does speak for itself. And I'm hoping to impart on you some wisdoms about its utilization and its compassionate efficacy in the wound management, tissue removal, and debridement and biopsy space. Just a brief disclosure slide. Dr. Lonke, as she mentioned, I'm the chairwoman of his advisory board. I also receive support and honorarium from a sundry of other suppliers in our industry, Convatec, Maricris Biotherapeutics, Keen, and ETS Miragen, along with Aura Biosurgery and STEM Labs. Dr. Lonke is, of course, the innovator and founder of Histologics, and you'll get a little bit of a snapshot of the history of Kylon during this talk, but we'll mostly demonstrate the optimal use of the fabric in clinical procedures, leading to a clean, debrided wound as well as a biopsy wound. We'll demonstrate some of the preclinical science behind frictional hooked fabric auto-tracked biopsy in sample for lab testing, but also show some data about how the tool itself effectuates an immunoresponse during the procedure. We'll analyze a few cases and demonstrate that with a video. And then Dr. Lonke will have his cameo moment in a video slide to explain and do some teaching on best practice when using and deploying K-Bride, which will be the focus of this talk, which is one of a sundry of the different tools in his Swiss Army knife cadre of products. And then finally, we'll touch on the reimbursement and coding strategies when deploying Kylon in your practice. So this is a proprietary hooked fabric. Think of it as maybe the aggressive side of Velcro. However, the hooks are specialty cut in the manufacturing process, and it's considered an FDA medical device. These sickle-shaped hooks are flexible when pressed into soft tissue, and I'll emphasize soft tissue here. Those hooks actually unfurl and become micro curettes when you press and twist or rake with force. Now, if you're just lightly raking, you'll maintain the sickle shape, and you'll be less of aggressive debridement or biopsy. But we'll go through some of the different scenarios in which you'll want to rake versus press and twist or force the curettes into the tissue. And many times, of course, this is offering a gentle patient experience. And in my practice, patients actually like when I use this over the sharp cold steel that we've chosen in our history. So like any any innovative company, we have tissue-based technologies to compassionately save lives worldwide. That is our mission, and our vision is to innovate, to remove, diagnose, or treat tissues prone to disease, also to save limbs and lives worldwide. So we call this a compassionate, value-driven, novel fabric-based technology. Dr. Lonke comes from a lineage of value-based care models, and when strategizing about this tool, of course, he always thought about how we can deliver value not only to our patients but to the industry at large. So, well, it's a translational product. If nobody knows, Dr. Lonke is an OB/GYN and had discovered this this technology and utilization in his endocervix and ectocervix sampling to determine the presence or absence of malignancy of the cervix. So many years of discovery during his tenured OB/GYN specialty to determine that this was a compassionate way to sample the cervix and get efficacious and reliable tissue samples to determine if a woman had cervical cancer, circumventing and trumping the traditional punch biopsy and endocervical curettage. So these are the before and afters of innovation of a tool. As you can see on the left-hand side in the GYN space, for colposcopy, we used pretty Draegerian tools, of course, cold hard steel, that would grab and pull tissue samples for histopath. But then, of course, into the 2020s, Dr. Lonke innovated Kylon, which has now become standard of care in has been used and deployed in over 2 million GYN cases throughout the United States and abroad. So in the late 2020s, most notably, Dr. Lonke then met the wound wizard and had already started to innovate in the space as a new novel debridement and biopsy sampling device, and translating his GYN tools into the wound care and wound debridement industry. And so it's been a mainstay product in my practice. We use it both for wound hygiene, wound debridement, as well as tissue sampling for highly reliable samples in the lab PCR space to determine the microbiome of this wound that we may be treating for critical or what we call the critical inhibitory bacterial load in the wound base to determine if patients need ongoing chronic antimicrobial treatments. And so it does help to make point of care decisions about what we're going to do to manage those critical colonizations and wound infections. So as I said, this is a value based type product. This is just Dr. Lonke's informed slide about the calculation of value to any program. And of course, it's increasing quality and service, but also access to compassionate tissue sampling and debridement, and of course, divided by the overall cost. And so as your value equation goes up, so do either cost goes down or these other access points go in the positive direction. So this is a frictional tool. It's going to have its benefits when it is placed in your hand and it's deployed into the wound bed, and whether or not you're raking or twisting and pressing and deploying those microcurettes, you're essentially effectuating a frictional frictional mechanism and increasing the heat of the wound base. So this on the left side of the screen is the newest SKU of Histologics called the K-Bride device. It is a measured handle, so there are measurements in increments of centimeters along the handle base to mimic what you would traditionally use as a curette to measure your wounds in real time during the debridement or post-debridement episode. And of course, that incurvated fabric pad for larger wounds and for wound margins. You can still press and twist, you can do the raking, you can do all the different types of mechanisms to really get a solid wound bed prep or wound bed debridement for sharp excisional, but also depending on how hard you push and what type of torque you use, you can also lighten it up and actually do more of a selective, and I'll show that in the video here in just a second. Of course, these are the other tools. The blue tool there is the K-RET device. It is actually great for crevices between toes if you're doing hyperkeratosis, for dermatitis in between the toe space. I use that particular tool for a lot of my nail debridements. If I'm cutting toenails and I'm managing subungual debris, this really actually helps to get that out of there as well. And then you have the soft biopsy, which is the purple handle device, and then the soft biopsy plus D, which is a little bit bigger pad on the tip there and more reinforcement to be more aggressive, to actually do the push and twist method to send off tissue samples to the lab for PCR. And of course, we want the best tissue sample in our PCR methodology. And so we typically do a light formative type of selective or sharp excisional debridement when there's a lot of buildup in either fibrin slough or soft tissue necrosis before we take a second sample of tissue to send for PCR. So this slide is to just explain, or to bring to mind the outcomes from Dr. Stillman et al. And Dr. Lonke many years ago, when they actually looked histologically at the, I guess, post-Kylon tissue, when they went back several weeks later to reevaluate the biopsy, site of the cervix. And what they found is that in the site that the Kylon had been utilized, there was a robust inflammatory cell-mediated immune reaction under that previous frictional fabric biopsy site. And these were looked at in between 2 and 3 weeks after the incident. So this just adds a little bit more color to the fact that perhaps it's not just a diagnostic tool, but a therapeutic tool. So this is just a video. I'll play it. It's about a minute long, and Dr. Lonke will explain the new K-Bride device.
We're not hearing the video, the audio. I don't know, but it's okay. I'll explain it. So what I'm doing is showing you that it's kind of jittery, but I'm showing you can actually cut with it, and I'm using the rind of the orange and showing that it can go right through it really pretty easily, and it can't really get through the skin of the orange that way. But if you're going at an island of fibrosis or something, you have to go through it along the lines of the softer tissue towards the firmer tissue. And if you actually press in from that margin and you go towards the more solidified tissue, you can trap the tissue, as you see, but you can also go right through it, and you can start shaving away some of the firmer elements. I mean, this isn't cold steel. It's not going to cut away callus, but it's not going to get like very solidified black eschar, but more of the fibrotic, thicker tissue. It's achievable, but you go at it from the softer area. And it's shaped so it can saucerize wounds. It's very good for the wound margin. So I think that's the best we can do there, Tracy.
Yep. And what he's explaining here at the end of this video was actually that you could retain the tissue, or you could excavate it with your finger, not a gauze, but your finger to continue to do additional passes. But if you were using this tissue for sampling, then you can snap off the tip. And all of the devices have this tip snap off, except the K-Cot finger cot, which I have not shown a picture of that. It was at the beginning of the slide deck. So this is just a still store and forward image of what the soft biopsy tool would be and use. And so basically perpendicular to the wound base, you're pressing and twisting into the tissue to get your tangential biopsy and send that off for PCR. Okay, so I will talk you through these two videos. The first video is a demonstration of utilizing K-Bride for hypergranulation. A patient presented with a chronic wound from a very humid climate, and he came in with, sorry, my computer is not cooperating here.
Looks like it's a still, not a video.
Yeah, it's linked to the Google Drive, and so it's not gonna run.
Yeah.
It,
So what I
it
suggest we do is when we post the video on our website, we'll have a link to the video so you can watch the debridements.
Right. So essentially what you would have seen here is me debriding with the K-Bride device to basically mow this lawn of hypergranulation tissue. And of course, I always hold a gauze pad while I'm doing that, so I can just add some compression as we go along to reduce the amount of blood loss. And then this other image was to just demonstrate the use of K-Bride to actually show that it does grab onto hyperkeratosis and does excavate that layer of margin, so you can do a really good marginal debridement.
Yeah, I thank you. And I would just add that this is very precise, so you can go millimeter by millimeter. So you're not disrupting the healing wound and I saw how much bleeding you had, and it was more than we usually see, but it was definitely controllable. And sometimes you want to induce bleeding too, right?
Yes, so yes, we definitely like, sorry, my cache is being becoming somewhat temperamental here. Okay. We would like to see that bleeding because we're essentially putting giving the patient an opportunity to have some autologous products residual in the wound base after your debridement. And we know that doesn't hurt the patient. If anything, it may have, depending on the number, obviously the commercial products, the commercial autologous whole blood products out in the market, have a lot more science to determine that they're the amount of number of cells that they're delivering with their patch or their clot. But ultimately, it's providing a moisture bed. It's also providing glycosaminoglycans and additional hyaluronic acid and all the things that actually cause the wound bed to be sticky. So when you're placing a CTP, you get that adherence when you leave blood product in the wound base. So this slide is busy, but basically it's a great reference tool to print out in your office and provide to your billing teams to actually go and remind of the different CPT codes that could be used or could be billed when you've deployed Kylon. And so since Kylon is considered an FDA similar to a curette, just any procedure that you essentially would use a curette or scissor or sharp instrument to perform, you are billing for those procedures in your office. And so the selective debridement codes, the 975, 975, 97, and 98, depending on wound surface area, as well as the 1100 codes, for wound tangential curettage biopsy. And we use that code, the 11102 and 103, depending on how many specimen or passes we're sending. We'll go on the super bill if we're doing a biopsy for PCR. And then, of course, the 11042, 45, 43, 46. Those are going to be your sharp excisional based on surface area, primary and secondary codes that you would be able to bill for. And then, of course, describing the tool in your procedure note as you would typically write in your template. Instead of using a curette, I typically just write Kylon curette. I just add the word Kylon or Kylon hook-based fabric, and as the tool description in the procedure note. And then lastly, is very interesting to me because I'm an interventional wound care specialist, but in the previous venues in which I worked, I did more 9.7, 5.97s and 5 and 7/8 9/8, excuse me, and excisional debridement versus true wound excision for surgical preparation of the placement of a skin substitute, autologous skin substitute, or a negative pressure wound vac. So it's these 1,500 codes, these 15002 and 003, which can be performed typically only once in the episode of care, at the beginning of care, where you fully excise the wound with a surgical instrument, and Kylon can be that instrument. And then finally, he does want to let you know that there is an A code for a general surgical procedure, surgical supply that, depending on your place of service, may or may not have an allowable fee scheduled amount. So the various different methodologies, as touched upon during this talk, are here. The paintbrush technique for wound hygiene or non-selective abrasive or mechanical debridement, that's your 97602 codes. Those are typically deployed from a coding standpoint in a place of service 22 or hospital outpatient department. Although a lot of this is going to be changing in January, we don't know quite sure what the unbundling is going to look like and which particular CPT codes for debridement are going to be allowed as the incident to or the incident for the incident to supply billing that's going to come down the pike. But nonetheless, the paintbrush technique would certify or validate this 97602 non-selective abrasive mechanical debridement code. When you pressurize the tip and sweep for lighter excisional debridement, that turns it into a selective excisional tool. And then when you press and twist or flatten the hooks completely, and you really excavate solid soft tissue and slough and necrosis, then that's going to be your 11042s and 43s, 44s and 45s. So that's your excisional wound bed debridement. And of course, just reminding that effectuating micropunctate bleeding is good for neovascular effects. And also to remind from a teaching standpoint that you may not be able to effectively debride fibrotic heart or solid eschar or bone. You would need to turn to a sharper instrument for that. So in conclusion, Kylon being a proprietary flexible sickle hook nylon fabric that allows for minimally invasive and compassionate biopsy and debridement. It is becoming the standard of care for wound-based culture or molecular analysis of biofilm to determine antibiotic resistance genetics and basically assist providers to make point-of-care decisions about what not to prescribe, and perhaps even formulating a compounded topical antimicrobial program for the patient that may have better efficacy than trying to give them a pill to swallow or an IV through their vein. So it's versatile. It's obviously for both non-selective and excisional surgical selective debridement. And as I said, my patients ask for it. They do not fear the finger. And at a cost of around $5, depending on your tier level and volume, GPO, et cetera, could be considered the most affordable and efficient tool on the wound care market for sampling and debridement. So I think that is the end, and we'll open it up for questions.
Aaron, you're monitoring the questions, right?
Yeah, so I just allowed everyone to unmute themselves. So if anyone has any questions, just feel
Or
free.
they can put it in the chat.
Yeah.
And I'm going to
While
throw
we're
out
waiting,
the coding and reimbursement slide while we're chatting, because that may
while we're waiting for the chat, can I share my screen?
Mhm.
Can we switch over? I have your video. Maybe it'll play. I'll just show a little piece of it.
Yeah, I'll stop my share and see if we can
Okay.
do that.
Yeah, here we go. All right. Can you see it?
Mhm.
I'm gonna take your volume down so you don't, so we don't have any patient identification issue.
Yes.
Yeah.
Yeah, I had been explaining kind of step by step what I was doing with the
So
patients.
why don't you just narrate over it so you can
Sure.
tell them?
So as we started to go ahead and like I said, mow down the hypergranulation because we wanted to really fashion those margins and assist with the epithermal migration or epithelial migration from those marginal areas in consistence with the timers model, right? So so we basically were loosening up those hyperkeratotic edges and then adding some very strong force, downward force pressure to excavate that excessive hypergranulation or proud granulation tissue right there in his
Right.
wound. And this patient, just for the audience, this patient is fairly asensate. His wounds have been there for greater than 6 months. And he was actually living in Hawaii when these developed. And so he came to the US with only maybe a few weeks before seeing us. And so we felt like the reason for the hypergranulation in this regard was critical colonization. So we did end up sending a sample of tissue for PCR, but also excessive moisture control. So so we did change things up, but we're not using any kind of CTPs or any collagen in this patient's case specifically. He just comes on a weekly basis, and if we have to do more debridement, we will to get those edges to contract, but they are already. So
I'm gonna make one quick comment. You can't do that with a Debrasoft, and you can do it with a sharp, but you're not going to get as precision because she's going literally a millimeter at a time here and basically modulating it with the pressure that she's putting on it. And she wants some bleeding. She wants to stir it up. She wants to get the root wound revitalized. So it's got the precision of the microcurettes, but it's got the efficiency. If you had to use something very like a gauze or some other cloth and it's very, very inexpensive compared to some of the other alternative debridement tools that try to do something similar. So we've tried to keep these certainly under $6. This has the added benefit of being able to measure the wound with the handle. So how do you want to finish up? It looks like you're finishing up that wound in pretty much record time there, Traci.
yeah, we do that wound's about 45 square centimeters. So I mean, it was under a minute to get through it, and then of course we did add the gauze, and we waited for some hemostasis.
Right.
But I try
Right.
not to use a ton of hemostatic agents. Typically I'm using collagen or pressure or Prisma that has the RORC for hemostasis. But I'm not, unless I have moderate to severe bleeding because they have venous hypertension or some other cause, then we typically are just using gauze and pressure hemostasis.
Right. Right. So
Which is where the time
typic
comes in. It's not the debridement, it's the hemostasis phase that
right.
adds time to the procedure.
So she's not going to snap the tip of that device off and send it to a lab because it's full of surface contamination. She's cleared the wound bed to the base, and that's where the biofilm resides. So you could take one of the purple devices, which is purely soft biopsy for a wound biopsy. That's all it does. And you could press and twist it into some areas of the wound and snap that tip off. And now you've got an independent device. For most cases where you're doing that would be selective sharp debridement, what you did right there, right, Traci?
Actually,
So
that's an excisional because we were
okay,
removing
yeah,
subcutaneous
vital.
vital tissue.
So that would be 11042 or 3.
Correct.
So then she couldn't bundle a biopsy of 11102 at this point with the debridement. She'd bill one or the other. But let's say it wasn't that bad and she was just cleaning it off mechanically and didn't bill for it, and then gets to the wound base, she could buy it. She could bill for it because
That's
if she's
correct.
only coded, yeah, go ahead.
And in this case, if we were to do the 111 103 or 102 103, our we would typically bill the biopsy as the primary, and then we would modify the debridement preparation because it's really preparing the wound bed for a biopsy, which is the diagnostic
Right.
intention of the
Right.
visit. So we would bill for the diagnostic, and it would bundle with the debridement inside of the diagnostic.
Right.
And I mean, the allowable amounts, depending on your MAC, are not unreasonable. They're definitely in the 90s to $110 range for a tangential biopsy. And of course, reminding that it doesn't take into the fact that you have a square surface area there that you've prepped. The biopsy is incident by the individual unit of the lesion that or the biopsy pass. So if you ended up taking multiple biopsies, then you would be billing one unit for the 11,102, and then you would multiple unit the 11,103 to match the number of biopsies that you take.
So just to conclude, because we're almost out of time, did we have any questions that came up? We've created something that has tremendous versatility that meets the value equation. So the quality you got to see, it actually can cut, or it can be very gentle and just wipe debris off. The biopsy actually has to be independent of the debridement because you need to get the necrotic stuff off. And that's true for histopathology as well. Greg Schultz, the late Greg Schultz, who was an early advisor of our company, taught me that tangential biopsy of the wound bed is the gold standard for culture, not only for molecular testing, for culture. And we've created a very rapid, precise, auto-trapping, easy to do tangential biopsy tool with the patient care experience of the swab, which the swab, which the value equation is the quality, which we've shown you. It has very versatile quality. And then it's the service. The service means patient and provider willingness to do it and the patient care experience. People don't feel this very much. That was an A sensate patient, but usually you can use topical anesthesia for the ones who are sensate. And we've taken some people and prevented the OR. We have some publications on that. The last one is access. And you could see it took her a minute to debride that wound. And time is money for all our wound care providers. And it's also, patients love it when it's over in a minute. And they won't fear you as much when you come to the next one. And we're very proud to be able to offer it at a very affordable price. So that's the cost. So as the value goes up in the numerator, the cost goes down in the denominator, the total value goes up. So we are hoping to replace some of your cases. We have samples available. I think the communications to and from, I think Lily and Zuhal will reach out to give you guys some samples or whatever. So do you want to say anything last words before we end, Traci?
I have no further comments, but thank you everybody for your time, and you can certainly reach out to me at Dr. Traci K at thewishclinic.com if you have any follow-up questions if you'd like to have like a peer-to-peer conversation about any of the topics and items that we discussed today. Please don't feel free to reach out.
And the A code is variable. It's a miscellaneous. It's not a miscellaneous code. It's a sterile device. But as we show more theranostic abilities of the device, they might be expanded in the future. We welcome feedback. Anybody who wants samples, wants to learn more. We're very popular, especially in the HOPD, let's just say mobile wound businesses now, because they can take it in their pocket, bring it anywhere. It's so versatile for the different types of wounds, and it's fast. So with that, I'd like to thank the people who are attending. I'd like to thank Aaron and Zuhal and Lily for arranging the meeting, and especially like to thank Dr. Kimball, the wound wizard. We will be at the SAWC meeting. If you're there, come visit our booth. We were just at the WOCN meeting. We were there the last 2 days, and we love working with all the various versatile wound caregiver spectrum of people who do this, and all the different settings that you do. It's a lot easier to do OB/GYN. It's like you have a abnormal screening test, you do a biopsy, and you get a result. But with wounds, it's very, very diverse. and I'm really learning to appreciate it. So with that, thank you very much for your attendance, and come back and communicate with us. Try the product. Hopefully you'll love it. Thank you.